Good morning. Thanks so much for having me. I love talking about trauma. I think it's kind of one of the things we do that really can have the most impact on patients. They come to us when really they're the most vulnerable. Oftentimes they're young men with their families and everybody's really scared. So at any rate, it's been a passion of mine for a while. So let's kind of talk a little bit about that. So I have no financial disclosures. Really, the objectives today are to kind of understand how to assess ocular trauma patients in an efficient manner, talk about what are the most, or the best and the worst prognostic signs when you see patients who've had trauma. And I think it's useful to know about the ocular trauma score. That gives us kind of a 6-month prognostic range of what the visual acuity might be, and that can be helpful as you think about patients and become familiar with more routine and complex cases. So in terms of assessing the patient, when we think about what the history was, the mechanism of trauma is probably one of the most important things to ascertain. Was it blunt force, penetrating or perforating, chemical or thermal injury? And as you're talking to the patient, you want to try to assess what the level of impact might have been. And then, the review of systems is important when you think about the worst the ocular trauma was. Maybe there was multi-system trauma. So exam fundamentals, the three most important things are visual acuity, and visual acuity in terms of their initial prognostic sign, followed, I think, closely by pupils. And I know in the office, in our routine patients, maybe the tech is doing that, but I always like to assess the pupils myself when I see a trauma patient, not just for the reaction and whether or not there's an afferent pupillary defect, but also the shape of the pupil that can give you a hint as to where there might be an iris sphincter tear or an iridodialysis or some focal trauma that can penetrate an IOFB. So again, APD is super important, and of course, we should remember that if the pupil is traumatized, the other pupil can help you assess if there's an APD via reverse Marcus gun testing. And then the IOP, is it too high? Is it too low? So, high pressures, you can see that in hyphema, retial bulbar hemorrhage. Low pressures, you should think about a ruptured globe or traumatic iritis or things of that nature. So looking towards the exam, of course, we want to look at the pH if there's a chemical burn. Hopefully anybody with a chemical burn, you're either seeing them in ER or they're being sent to you after being already flushed out by somebody on a first responder basis. So subconj heme, of course, that's pretty common, but hemorrhagic hemosis, of course, is a different thing. So if the conj is really bullously elevated with hemorrhage, you really should think about a ruptured globe, particularly if the IOP is low. And then if there's a conj laceration, those are pretty common again, and the sclera is much more robust than the conj, but you should think about is there's uveal show if there's a conj laceration, just to make you think there might be an occult ruptured globe. And then corneal lacerations, what's the depth? Is there iris to the wound? That could give you a hint about whether or not there might be a foreign body. And then the lens, right? Is there phacodenesis? Is the lens there? Is it floating around in the vitreous? Has it been traumatically expulsed or avulsed from the eye? All these things can happen. So posterior segment exam, the first thing is, what's the view, right? Is there vitreous hemorrhage? Is there opacity? When you're looking at the retina, is there commotio, scleropateria, a dialysis, a tear, detachment? All these things would kind of influence what your plan of action is going to be. And then the choroid, of course, can have ruptures and hemorrhagic detachments as well. The disc initially can have edema if there's traumatic optic neuropathy. It can also later on, of course, go to pallor. In rare cases, it can be avulsed, and I only saw that one time, thankfully. That wasn't that patient, but that kind of was what that looks like. So let's just talk about the ocular trauma score. This, I think, is really, really useful. It's available online for free. But essentially, you're going to get a raw score just by assessing what the visual acuity is. So they get a raw score based upon their acuity. And then you start subtracting things. So if they had a globe rupture, they lose 23 points, endophthalmitis, perforating injury, and the list goes on with RD and afferent pupillary defect. You generate a raw score from those numbers. Again, this gives you a 6-month range of outcomes for the VA, which is a good prognostic sign. And then once you get the raw score, then you plug it into 5 different categories. So again, if their raw score is 44 or low, they have a very high likelihood of having extremely poor vision. And you may not share that with the patient right off the bat, but at least you can say that the prognosis is quite guarded. Maybe your initial plan would be hopefully to save the eye, right? You're not talking about good vision necessarily. On the other hand, if their raw score is quite high, then they have a very good chance of having excellent vision. So this is just kind of a good thing to keep in the back of your mind. So for example, somebody comes in after trauma with a VA of 2200, they get 90 points for that. They lost 10 if they had an APD. They lost another 11 for retinal detachment. Their raw score is 69. And then raw score of 69, they have an OTS score of 3. And there's about almost a 70% chance that they're going to end up 2200 or better. So this patient initially 2200 vision, even though they've had some other bad prognostic signs, it's a pretty good chance they're going to end up better than they were. So that's just kind of practical thing to keep in mind. So let's talk about the good. So in terms of trauma, the good patients, essentially the walking wounded that come into your office. And these are reflected in patients that I saw when I was in Iraq with the 4th Infantry Division. Every combat division has optometrists and as their kind of frontline eye care provider. As part of the medical team, usually a combat division will have a battalion aid station as part of the division support brigade. So we saw a year of consecutive eye injuries, just about 170 patients. The good thing about Army paperwork is that you have to log each one. So at the end of the year, I just had this whole stack, and so it was really easy to kind of go through and assess what we did. Most of these patients had good acuity. The ones that had the more complex traumas were kind of air evac over my head. So I basically saw the walking wound, and our goal is really get these people back to their unit. We say in the Army Medical Department, your job is to conserve the fighting strength. So the common things we had were cornea conj, foreign bodies, abrasions, lacerations, chemical injuries. Uncommon things were the worst things like hyphemas, phacolytic glaucoma, and retinal detachment. So lost productivity, and that's one of the things that we tracked. How long were they away from the fight? And that was a bimodal distribution. Most patients were, a day or two max, and then the more complex patients were longer. And so we only had a medevac one patient for trauma for the detachment. Now you might say, well, what about the phacolytic glaucoma? You can't fix that. I couldn't, but it was an enemy prisoner of war, and I couldn't evacuate the patients. I really couldn't do much. So it's kind of one of the limitations of military medicine. You can't always do what you want if it's not part of the greater command mission. So this is a little ARVO thing that we did, and like you can see, visual acuity is pretty good for most of these people. Treatment time is pretty short. This is just time, minutes. And then lost duty hours, there's usually just a couple hours, with the more serious cases losing more time. So posterior segment trauma is usually what I usually would categorize as the bad, not always the ugly, but usually the bad. A lot of times these patients initially are seen in the ED or as an inpatient in the hospital if they've had multi-system trauma, and so they may see you for follow-up after. So again, the most important thing with these patients is what's the view, right? Can you see with the indirect, or you have to get a B scan or a CT scan? And lots of times patients in the ER, like a CT scan is just like getting a CBC, right? They almost always have a CT scan, which is super helpful. I think the goals in these patients, number one, is close the eye if it's open. That's kind of the most important thing, because you want to prevent infection. And then remove the IOFB, and I kind of deliberately put the removing the IOFB second. There's pretty good data out of Iraq and Afghanistan that you don't have to remove the IOFB immediately. A lot of these people, they close the eye, they give them an intravitreal antibiotic injection, and ship them off to Landstuhl in Germany, where that was the closest retina team. So I think that's a little bit of a second place, but definitely you want to get the eye closed. And then fix the detachment, of course. This is a guy I saw when I was attending at the university. Young 15-year-old. Of course, it's still about always young men who do silly things. This guy was on a rafting trip in Montana, and his friend hooked him. The good, I could have put this in the good category, not the bad, because look where this went in, like right around the pars plana. So this hook didn't get his lens, didn't get his retina. And, we vitrectomized probably because just that's what we're trained to do. We do vitrectomy. I'm not sure we needed to do a complete vitrectomy. But nevertheless, we just took an MVR blade after that, opened this up, took it out, and the next day he's like, when can I go water skiing? So, you gotta love young men, they're great. And the kid ended up doing really well. But they don't always. Some of them can do great, even if they look real worrisome at the beginning. So we had a 37-year-old guy who was hammering metal on metal. It's kind of the classic thing we think about. He took off his protective eyewear. All these guys, they tell you, right, I was wearing my eyewear, and then I just had to see something, and that's when, of course, it's going to happen. He felt something in the right eye, went to urgent care. So there's an IOFB. Of course, the metal is going to show up real hyperlucent on the CT scan. So pre-op, he was 20/40. But he did drop to the 2100 range as we were kind of getting him prepped for surgery. He was saying things were getting progressively blurry. So surgical approach to these people, again, he had a corneal scleral laceration. Of course, you want to close that. In my training, we tend to just put a buckle on all these eyes, and I'm not sure I do that anymore, but this was kind of early on in my training. Oftentimes, after a vitrectomy or during a vitrectomy, the lens is going to go south, and that's what happened with this guy. So as you're losing view, we often take the lens. Sometimes the IOFB just makes it really hard to get it out and leave the lens intact. And then laser and oil. Again, I'm not sure I would have oiled this guy today, but he ended up doing real well. So let's think about his ocular trauma scores. Raw score was 67. He had 90 points for his very good acuity. He lost 23 for the globe rupture. So again, ocular trauma score of 3. So pretty good chance he's going to be okay, but remember, his acuity was like really good at the beginning, 20/40, so you're not necessarily bringing this guy back to that. So right after the same day, there's a little bit of air bubble and the rest is silicone oil, but you can see, very luckily, his IOFB was here, not here, right? Just, what is this, like maybe 4 millimeters distance between good and bad outcome. But he did great. He stayed attached, and eventually, I took the oil out, put an ACIOL in. I know I'm saying ACIOL, and most of you probably looking at me like this is the Stone Age, but they actually work. He ended up 20/25 and was very, very happy. This other guy I just saw earlier this year is a 19-year-old man. I'm putting man in quotes. I have a 19-year-old. I'm not sure I'd categorize them as men, but they're sort of men in training, right? And so they're kind of trying to become men and doing things that might not always be so smart. So this guy was trying to help his dad, which is always another bad prognostic sign. And they were chopping wood, and the wood of the axe, where the axe handle met the wooden, the axe head met the wooden handle, was loose. So his father said, "Oh, you just hold it, and I'm just going to hammer down the axe handle into the wood." And so of course a piece of the axe went into his eye. So he had a ruptured globe repaired by a local colleague and was sent to me the next day for IOFB. And again, I think that's perfectly fine. Not everybody has to do everything. And the very next day we took him for IOFB removal. So this is kind of a little hard to see, but I think the salient thing is that he's got a lot of blood here, and he's got a little air bubble from having, just the eye open. And the IOFB is kind of up here, kind of obscured by the blood. So his pre-op was 20/25. So this is kind of a scary moment for the doctor when they're seeing so well, but they're about to not see that anymore in all likelihood. So I was really worried about this kid. I think other things in terms of good prognostic signs from a vitreoretinal standpoint, the pathology was pretty posterior, and so I think that bodes well in the future, hopefully for him too. So his ocular trauma score, so his visual acuity is really, really good. So he starts out with 100. He did have a globe rupture, so he's at 77. And he didn't have a perforating. So he had a penetrating injury, but perforating, right, perforating is through and through, so he didn't have that. And he didn't have an EPD. And so he was sort of in the 90s range, so he has a pretty good chance of actually seeing well. Of course, the approach for him is vitrectomy. I didn't do a lensectomy because his lens is really clear, and we were able to get the IOFB out without dinging the lens. I did tell them that probably within a year he'd lose it, but so far he's actually doing well with that. We took the IOFB out, lasered his break. I didn't put a buckle in the eye, and I didn't use oil. I think I probably would have initially in my training, but like I said, I think the pathology was so posterior I didn't really see a big benefit. So initially, his post-op, you can see I put a full air bubble in, and it's regressing, and you can see where we lasered. It's probably a little easier to see on the autofluorescence. And then 1 month later, he's actually seeing 20/20, which is quite remarkable, and hopefully he's learned his lessons. We'll see. Next thing I want to talk about is the bungee cord trauma in the left eye. I don't know about you, but I think bungee cords should either be illegal or come with safety glasses in the case. I mean, I've never seen worse things than bungee cords. So this guy he had a bungee cord trauma, was followed by a glaucoma specialist for hyphema and iridodialysis. As this hyphema is clearing, they're noticing a detachment. So he was sent to me with a MAC-off RD, count fingers in the left eye. And my staff, it was at the end of the day, they didn't dilate his other eye, thankfully, because I wouldn't have been able to see that he did have an APD via reverse. And so that's going to become important. So again, he's sent with a MAC-off RD, but his detachment, he's MAC on, right? So he's count fingers with a MAC on detachment. So that's traumatic optic neuropathy. And thankfully, like I said, they did not dilate his fellow eye so we could assess that. Because I would have otherwise thought, wow, you've got a pretty good prognosis. Your macula's on, right? So I just did a buckle on him. He's a young phakic guy. Did a little cryo to his dialysis, and he did well. His ocular trauma score is 59, right? Because he's got pretty good points for the VA, but he loses 11 for the RD and 10 for the APD. So his ocular trauma score is actually a 2, which, it's kind of a mixed bag as to what the outcome's going to be, but definitely not great. And, 1 week later, he's totally attached, but his visions still count fingers. But thankfully, I noticed the APD and I was able to tell him, I don't really think your vision's going to get much better because his macula was on to begin with. So, again, I think expectations are important, and he was happy, not thrilled, but he understood that it was not necessarily going to improve his vision, but prevent further demise. So moving a little bit into the ugly, so gunplay always is going to give you ugly results, usually. Is a 48-year-old guy. This is a terrible, terrible story. He was the victim of a shotgun blast while hunting. His brother-in-law heard him moving and wheeled around and fired. So he took a face full of birdshot. His right eye was hand motion, very, very hazy with a vitreous hemorrhage. Left eye was erytitis, no light perception. He had birdshot scattered in his face and his neck. He almost died out in the field because he almost nearly totally lacerated his right common carotid. So this is really, really tough situation. So really not a good view looking inside. On CT, he didn't have an IOFB. He did have birdshot in the orbit, which we planned on leaving. Usually that's inert, so we did not want to muck around there. So again, the goal is to close his eye, put a band on the eye. Certainly, do vitrectomy. His lens was pretty cloudy from the beginning, so we plan on taking that out. Get some laser in the eye, put him under silicone oil. His OTS score, this is also illustrative, so very, very low. So he had only 70 points for his low acuity at the beginning. He loses 23 additional points for the globe rupture and 14 for the perforating injury because it's through and through. So his OTS score is 1, and so just to remind you, he's got a very, very high chance of having hand motion or worse vision. So remember, his other eye is no light perception. This is an eye you might not operate on if his other eye was perfect, to be quite honest with you. So we try to do something. So we put a real high posterior band on to kind of support the area where the birdshot left the back of the eye. This is an oil-filled eye. He's got a lot of hemorrhage here. And then as he's healing over time, the hemorrhage is starting to regress. But you can see this from all the blood. He's getting really a dense kind of band of scar tissue here. And that, despite the high buckle, started to cause traction detachment here. So being young and foolish, sometimes being foolish can still lead to good outcomes. I kind of went in and I thought, let me just get rid of the retina here that's being pulled off and laser it back down. And so we did. And so he's got a little focal retinectomy. I was eventually able to take the oil out, and he, at this point, is kind of 2120 or 2125 to 2200, kind of, he's got a variable. It depends on the day. He's still aphakic. He's got these low vision electronic glasses for near work. This is, like I said, a 40-something-year-old guy. Of course, he's not driving. He switched work and home roles with his spouse. This is a complete change of life for this guy with 2 young kids. I would say, though, that what I said at the beginning, sometimes these are our most important cases, and this kind of an outcome is really important, I think, for somebody who otherwise would have no vision whatsoever. So in summary, again, a focused history and a focused exam can help elucidate the mechanism, the structures that might be involved, give you an idea about what the ocular trauma score is so you can think about what their potential acuity might be. In terms of primary eye care, these are usually the walking wounded and have better outcomes, but you should be on the lookout for poor prognostic signs, particularly APDs, IOFBs, or signs of infection. And again, on the posterior segment side, hopefully these patients have had an ED consult and a CT scan if there's no view. Otherwise, a B scan is super helpful. And posterior segment trauma, lots of tools in the toolbox to try and save the eye, but sometimes it's not possible. Again, as I said, these are life-changing injuries, but they're not life-ending. And I think being able to communicate that with a patient who is typically a young guy, who's otherwise in the prime of his life, this is really a big, like a psychic injury and a life-changing injury. But I think it's our job to kind of support them through that. I know I just kind of went through a lot, but I'm happy to answer any questions about trauma or hear about your experiences.
Yeah.
So one question that we run into sometimes, we'll often get ruptured globes referred in, and of course, initial objective is plug the hole,
Yep.
which we do. But often, in subsequent days, you'll realize, yeah, they've got a pretty bad traumatic cataract, or they got a lot of vitreous hemorrhage, not really a great view. What is the ideal timing for referring these patients to retina, and what is the ideal timing for retina to operate on these patients?
Yeah, great question. I think the ideal timing to refer is whenever you think of it. Like whenever you get the idea in your mind is a great time to refer. And we're happy to see these patients with you and come up with a plan together. I think it's always good to, when you have somebody who might have a complex injury, like sometimes the more input, the better. The ideal thing for timing, I think, kind of depends on what the status of the posterior segment is. So if I think we've all had the experience that B-scan is not perfect, right? And sometimes you're not sure if there's a tear. I think when there's a terrible detachment, it's pretty easy to see. But sometimes it's unclear. And so the more questioning I am, the more likely I am to go in. I think blood can be a big portion of what's in the pot for potentially getting PVR, and so sometimes the sooner you get the blood out, the better. And these patients, by the way, I don't think I mentioned, but I usually do them under general anesthesia. First of all, I think young men do great with general anesthesia, and eyes that have been traumatized do better with general anesthesia. I think you can avoid just bad scenarios in the OR. But I think OR timing is situation dependent, but referral to retina, I think, is as soon as you think of it.
So I have a comment question for you. On these traumas, they commonly merit multiple procedures.
Yeah.
And we just finished a couple of really great medical legal talks prior to your entry today, and the thing I'm thinking of is, it's in my mind always been good on consent on any of these traumas to include in writing, you may require multiple procedures, or say that in writing and say that in person, because I don't want them to think we're one and done.
Right.
Because that isn't true.
Yeah, I think that's a great point, and I'm sure you all have the sense too that our services are kind of getting commoditized, right?
Yeah.
I've had people say, I don't want my detachment repair at this surgical center on this day. I mean, it's like going to McDonald's, right? They just kind of think it doesn't matter. You can pick whenever you want. So I think giving them the idea that this is maybe multi-steps, the outcome may not be good even with multiple surgeries. All of that is super important. And to your point, even on the consent, we put let's say vitrectomy, possible sclerobuccal, blah, 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 and other necessary procedures, right? We put that in the consent as well, because sometimes you don't know what is going to be necessary when you get in there.
Oh, here, I'm coming.
Hey, as a new senior resident, I've had the joy of embarking on this journey. And what are your tips, I guess, in terms of counseling patients? Because we've had patients that are NLP coming in, and they've got a globe rupture, they've got all these, and their ocular trauma score is 1. And you'd mentioned in a healthy 20/20 other eye, those might be ones where you tell the patient, hey, maybe this isn't the right surgery for you, maybe there's something else. Could you tell us, I guess, how you would go about counseling a patient on that?
Yeah, no, that's a great point. I should say I've never really not operated on somebody unless their other eye was Tysical already. So like this other gentleman, I didn't operate on the second eye. I thought there was, the eye was just totally crushed. And similarly, I had a patient in a very similar situation, and I didn't. But when the other eye's okay, I try and advocate for a full court press because you don't know. And I've had people, which I'm sure you've experienced as well, sometimes it's a second opinion and they were told they need to go right to evisceration. And maybe I just haven't been around long enough, but I always like to give it one good try, And by that, I counsel them by saying, you may not recover any vision. We may just be saving the eye. In the worst case scenario, you may lose the eye anyway. And that discussion, I generally say, is most of the time if patients lose an eye, it's because cosmetically it's going to look better with a prosthetic than it would in the current state. And we're not going to force it on you, But I like to just give it a full court press and get all the blood out of the eye, see what we can salvage. And sometimes you're pleasantly surprised. Not always, but sometimes.
Next talk. Oh, you got one more?
Hi. Kind of related to that, what are your thoughts around the risks of sympathetic ophthalmia, and especially with these patients potentially needing, multiple retinal surgeries? I know that's also a risk for that. And just, would love to hear your thoughts on that.
Yeah, that's a great question. And I almost would defer to Dr. Petty, who has a lot more decades of experience. I feel like sympathetic, I've heard about all through my training, starting in optometry school in the year 2000, and I've never seen it. And I don't know if it was more common in the past or we're better at treating it, getting on top of it with steroids now. But I haven't had it be a huge issue, and I'm not sure if just our techniques are better now or it's more manageable now. But I'm not sure if you have any input, Dr. Petty.
I saw a few cases in my many decades of being in retina work, and there was a time when I, really if the other eye just had no potential, and the better eye turned out well, I would end up enucleating the other eye. But I have to admit that it's a rare event to get sympathetic. So the question is, what is best? I'm not sure.
Yeah.
Go to the next talk.
Sure, yeah.